so today we're going to talk about your general assessment of your preeclamptic patient. So for time purposes, we're going to assume that either the patient comes in with complaints of possible blood pressure problems for whatever reason, or that she came from the doctor's office with high blood pressures. So what are we as the nurse going to do before we call the doctor and let them know what's going on? Because that's what students tend to want to do is patients here says her blood pressure's up, or she thinks her blood pressure's up, and students automatically want to call the doctor. Well, there's responsibilities that we have to assess the extent of her blood pressure. First and foremost, I'll point out that she is not flat on her back. Okay, she's tilted off of her back to prevent that supine hypotension syndrome. She's obviously pregnant, so we would want to check the status of our second patient by applying the external fetal monitors if she's greater than 20 weeks. Check fetal heart rate by Doppler if she's in between 12 weeks to 20 weeks. The TOCO monitor for contraction purposes. Also, if she has complaints about her blood pressure, obviously we would want to check her blood pressure, along with a set of other vital signs. I would listen to her lung sounds to see if there's any pulmonary edema going on with my stethoscope. If she's got any fluid overload going on, I'm going to hear some pulmonary edema. I'd also want to ask her questions. Not only am I assessing her level of consciousness, but I want to know if she's had any headaches, any visual disturbances, is she seeing any spots? Any complaints of any edema. Lower body edema is normal in pregnancy. However, if it starts pitting, that's abnormal, or if she complains of upper body edema. So can she no longer move the rings on her fingers? Is she, are her eyes swollen shut, or her face, periorbital edema, is her face swollen? Those are bad signs when it comes to preeclampsia. I'm also going to assess, is there any epigastric pain going on? And it's usually not, it might be a little pain up here in my stomach. It's usually in an intense epigastric pain here in their upper stomach. When they come in, we usually have them urinate in a cup for us, and we dip that to test for any protein in the urine. The larger amount of protein in the urine, the worse the condition of preeclampsia that we have going on. Because the kidneys start shutting down and not working, then we start spilling protein in the urine. Ask her if she's been voiding okay. The decreased urine output is seen with preeclampsia because the kidneys start shutting down. We also are going to assess for her reflexes. So preeclampsia stands for, or means actually pre-seizure activity. Eclampsia is seizure activity. So you think of someone having a seizure, everything's very hyperactive. And preeclampsia, we're getting closer to that state. So in preeclampsia, you're going to see hyperreflexia. So if I check her patellar reflexes and she's preeclamptic, she's going to pretty much almost kick me in the face. Also clonus, if you check, just like you're checking for a DVT, and this is clonus, and you let go of the foot, if it's positive for clonus, that foot's going to tap back. And that's again because everything's hyperactive with your preeclamptic patient. Ask her if she's had any sudden weight gain. 3-4 pounds in 1 week, that's too much for a pregnant lady. Has she weighed herself recently, and has she seen a sudden weight gain? Has she had her lab values checked? If not, that's probably something that you're going to expect to see ordered. But if she has had her lab values checked, you're going to look and see what those lab values are, and we'll talk about what values you watch for in your preeclamptic patient. So what do we do? For a patient, so you've assessed her, you take her blood pressure, say it's 160 over 100, she's positive for, pretty severe preeclampsia, and with experience, you get to know, which ones are going to be worse off than others. But you call the doctor and they order what the drug of choice is for the treatment of preeclampsia, and that's magnesium sulfate IV. You need to become very familiar with the magnesium sulfate. It's given, a bolus dose is given, so you can get it in the system and get a therapeutic level very quickly. So you can treat the mother and the baby very quickly, and then it's turned down to a maintenance dose. The bolus dose is usually given over 30 minutes, and then the rates turn down. It's important to note that the bolus dose is usually given in a separate bag, just to prevent overdose. Usually your severe preeclamptic patients are put on fluid restrictions, so you're not going to give them a lot of fluids. Think they're already extremely swollen, maybe possibly leading to pulmonary edema anyway, and they're not putting out that urine output because their kidneys aren't working. So if we give them a lot of fluids through their IVs, we're just going to complicate that even worse. So we do hang regular IV fluids as a primary line, but we usually set it at a very low rate. And then we usually piggyback the bolus dose through that main IV line. And again, it's usually given very quickly, over about 30 minutes. This is a 100 cc bag. But you have to stay with the patient because respiratory depression is a side effect of that, and of course you don't want that to happen when you're not in the room. Magnesium toxicity. You want to tell the patient when you start the magnesium that she's going to feel hot and flushed, and she's not going to feel the greatest, maybe a little sedated during that bolus dose. She's not going to feel the greatest. But once you turn that down, she may not feel, like a spring chicken. She won't feel great, but she will be conscious. She will not, she'll be able to move in the bed. We'll keep her on bed rest, but she should still be able to talk. Communicate with us and whatnot. If she becomes where she's slurring her speech, non-responsive, breathing less than 12 a minute, her reflexes are no longer reactive, so they're absent. Urine output's less than 30 cc's an hour, then you're looking at maybe magnesium toxicity. And the first thing you want to do with that is you want to turn that magnesium off. Okay, so that's your first step with magnesium toxicity. Your second step would be to give the antidote to magnesium toxicity, and that's calcium gluconate, and that's given IV. So anytime you start magnesium sulfate, you always want to have calcium gluconate available at the bedside, just in case A, your patient gets toxic, or B, they go into respiratory depression. Something else, like I said, we're going to dim the lights, restrict visitors. Something as simple as turning the TV on can aggravate a patient's preeclampsia, so maybe, keep the room quiet. Extra visitors are discouraged. She's on bed rest, so most of the time, not only are we going to take strict intake and output, but to closely monitor that urine output, we're going to insert a Foley. So just for your memory purposes, that way we can closely monitor per hour how much urine output she's putting out. Now once her body starts responding to the magnesium sulfate and it starts treating the preeclampsia, then you will start seeing the mom diurese and start putting out a lot of urine, and that's a good sign. Of course, the whole entire time we're monitoring the fetal heart rate and making sure that there's no distress there. If there becomes a point where there's fetal distress, then obviously we would do an emergency cesarean section.